Hi, I'm Fahad Khalik and welcome to Golden Nuggets for Obstetrics. Now, the first thing I would like to tell you is the normal BMI for a woman now is between 18.5 to 24.9 kilograms per meter square. Anything less than 18.5 is called underweight, and anything more than 24.9 is overweight. Next is the total weight gain for a normal woman in the pregnancy, and that should be between 11 to 16 kilograms. Now, next is the macrosomia. Now, this is the baby that weighs more than 4.5 kilograms. Now, these baby are mostly going to be hypoglycemic, and they are the babies from the diabetic mothers. Next is the heart rate limit for the exercise during pregnancy. Now, in the pregnancy, it's appreciated that you do some basic exercise. Now, if the age of the woman is between 0 to 20 years, she can maintain her heart rate between 140 to 155 beats per minute. If she is in her 20s, she can have heart rate of 135 to 150 beats per minute. If she is in her 30s, she can have heart rate between 130 to 145 beats per minute. And if she's 40 plus, she can have a heart rate of 125 to 130 beats per minute. Next is the breastfeeding. Breastfeeding is started 30 minutes after birth. Very important. The examiner is going to ask you about this. So breastfeeding is started 30 minutes after birth and it is continued up to 2 years. So 6 months to 2 years is the best time for the breastfeeding. Now, if you talk about the exclusive breastfeeding, is the breastfeeding in the first initial 6 months. Now, in the first trimester, the blood pressure normally falls. That's because of the vasodilation and it's a natural phenomenon. Now, in the second trimester, the blood pressure increases and it increases by the end of second trimester. Now, if you talk about the anemia, we can have anemia in the first trimester, second, third, and postpartum. Now, if the hemoglobin concentrations are less than 11 gram per deciliter in the first trimester, the woman is going to be anemic. And now, if you talk about the second and third trimester, anything below 10.5 gram per deciliter is going to be anemic. Now, in the postpartum period, if the hemoglobin concentration are less than 10 grams per deciliter, this is anemia. Now, for that anemia, you're going to give iron trial, and the trial period is going to be 2 weeks. One more thing you're going to concentrate is the ferritin levels. You have to keep the ferritin levels greater than 30 micrograms per liter. This is very important. This is microgram. Now, if you talk about the gestational thrombocytopenia, it's the platelet count that is less than 100 into 10 raised power 9 per liter. And this gestational thrombocytopenia is seen beyond 28 weeks. So it's seen 28 plus weeks. Now, if you talk about the anti-D, first you can have anti-D administration that is secondary to some exposure, and that exposure is in the first trimester. So you're going to give the woman anti-D as soon as possible within 72 hours. And if 72 hours are not possible, you can at least give anti-D treatment within 10 days. If the woman is pregnant and the duration of pregnancy is below 12 weeks, you're going to give 250 international units. If the duration of pregnancy is 12 to 20 weeks, you're going to give 250 international units within 72 hours. And after that, you're going to go for Clover's test for the further dosing. Now, if the woman is pregnant and the duration of pregnancy is more than 20 weeks, you're going to give 500 international units within 72 hours. And again, you're going to go for Calhover's test for the proper dosage. You can also give anti-D for the prophylaxis, and this can be given either in form of 1 dose or 2 doses. If you're going to give 1 dose, you're going to give it at 28 weeks. And if you go for 2 doses, you're going to give it at 28 and 34 weeks respectively. And also you're going for anti-D administration, and this is done in the postpartum period. So you're going to give anti-D at exposure less than 12 weeks, 12 to 20 weeks, more than 20 weeks, also for the prophylaxis and in the postpartum period. In pregnancy, blood group assessment can be done at 28 weeks. Now, if you see a woman with a positive previous history of gestational diabetes mellitus, you're going to conduct oral glucose tolerance test at first trimester. And if there's a mother that is unimmunized and she's infected with the rubella virus, you're going to give MMR, which is measles, mumps, and rubella vaccine right after the delivery. Now, if there's a woman who is positive with the hepatitis B, I mean her surface antigen is positive. So, what's going to be the treatment plan for her baby? Her baby is going to get hepatitis B vaccine in 12 hours, Hep B immunoglobulins in 12 hours, and rest of the treatment is according to the EPI schedule, which is just Hep B vaccine at 1 month and Hep B vaccine at 6 months. So Hep B vaccine and Hep B IgG, both. The baby is going to get both in the 12 hours, and rest treatment is just like EPI schedule. Now, if the woman is positive with AIDS, you're going to start the antiretroviral therapy at 24 weeks. Now, if you go for PCR and the viral load is more than 400 at 36 week of pregnancy, you'll immediately go for the C-section. In a pregnant woman, you can go for HIV screening either at booking, or if she misses at the booking, you can do it again at 28 weeks. Now, the dating and the first trimester scan is the scan that is usually done from 11 weeks plus 3 days to 13 weeks plus 6 days. Now, the normal range for the crown rum length is 45 to 84 millimeter, and CRL is again done at 11 weeks to 13 weeks plus 6 days. Now, before 14 to 20 weeks, you're going to measure the crown rum length, and after 14 to 20 weeks, you're going to measure the head circumference. Very important. Before 14 to 20 weeks, this is CRL, and after 14 to 20 weeks, this is abdominal circumference. Now, this is just a correlation between crown rum length and the knuckle translucency. If you measure the CRL and it comes out to be 45 millimeter, it means that the knuckle translucency must be roundabout or something around 1.2 millimeter. The same way, if you measure the CRL and it comes out to be 84 millimeter, it means the knuckle translucency must be around somewhere 1.9 millimeter. Now, if you see the knuckle translucency, we get two different values, median knuckle translucency and 95th centile. Median is the median value. Now, if you see 1.2 millimeter median knuckle translucency, it means this is just the median value, and the 95th centile knuckle translucency means this is the above cutoff value. So for 1.2 millimeter, the maximum value it can go is 2.1 millimeter. Anything above 2.1 millimeter is considered to be pathological, and this is mostly going to tell you about the Down syndrome. Same way, if you get medial knuckle translucency to be 1.9 millimeter, the maximum above cutoff value is 2.7 millimeter. Anything above 2.7 millimeter is pathological, and most likely it's going to be Down syndrome. So in summary, if you get CRL of 45, it means the medial knuckle translucency is around about 1 to 2 millimeter and the above cutoff value is 2.1. The same way, if you get CRL to be 84 millimeter, it means the median knuckle translucency must be somewhere around 1.9 millimeter and the above cutoff value is 2.7 millimeter. The symphysis fundal height is measured at every visit after 24 weeks. So every visit after 24 weeks. If you talk about the dating scan, it is done at the end of the first trimester. If you talk about the anomaly scan, this is done at 20 to 22 weeks. Now, the vitamin D dose for pregnant or the breastfeeding ladies is 10 microgram per day. Very important, this is micro. So 10 microgram per day is the vitamin D dose for the pregnant and breastfeeding ladies. Now, if you see a pregnant lady with a fasting blood glucose levels more than 100 milligram per deciliter, that's gestational diabetes mellitus. The same way, if you see blood glucose level which are postprandial more than 140 milligrams per deciliter, this is again GDM. So for GDM, fasting levels are more than 100 milligram per deciliter, and again for GDM, the 2 hours postprandial glucose levels are more than 140 milligram per deciliter. Now, if you see a pregnant woman who has a positive history of diabetes mellitus, which is gestational diabetes mellitus in the previous pregnancies, you're going to screen for the diabetes this time again twice. First at 16 to 18 weeks, and second between 24 to 28 weeks. And you're going to screen it through OGTT, which is oral glucose tolerance test. Now, if there's no history of previous gestational diabetes mellitus, you're going to screen it only once. which is round about between 16 to 18 weeks. So you're going to screen for the gestational diabetes between 16 to 18 weeks through OGTT if there's no previous history of gestational diabetes mellitus. Now, every time a gravida comes to you for the antenatal checkup, you're going to measure the blood pressure, urine, and SFH. Now, I cannot emphasize more. This urine is very important. The examiner is going to ask you about this. If you talk about the Down syndrome, you get the quadruple test and you get some other parameters. Now, this quadruple test is done in the second trimester of the pregnancy. You're going to measure the beta HCG, alpha fetoprotein, inhibin A, and estradiol, which is UE3. And the other parameters are PAPPA, which is pregnancy associated plasma protein A. Again, macrosomia, the babies that weigh more than 4.5 kilograms, these babies are generally hypoglycemic, and these are the babies of mothers with the diabetes. Now, the gestational age, which is along the 75th centile, is called the normal gestational age. If it's less than 10th centile, this is small for gestational age. And if you talk about the amniotic fluid, the amnion secretion starts at 10 weeks. Then this amnion adheres the chorion round about at 12 weeks, and mostly the secretion is from the skin of the fetus. Then round about at 16 weeks, the kidneys and the lungs start secreting this amnion. Now, this is a very high yield table, and you must memorize this. Now, at 10 weeks, the amniotic fluid level is around about 30 milliliter. At 20 weeks, it's 300 milliliter. It's gradually increasing. At 30 weeks, it's 600 milliliter. At 38 weeks, it's maximum, which is around about 1 liter. And after that, the level starts falling. For example, at 40 weeks, this is around about at 800 milliliter. That's because the fetus is swallowing this whole of the amniotic fluid. And at 42 weeks, that's only 350 milliliters. Now, small for gestational age is the baby who has reached his growth potential, but he's just constitutionally small. There's no pathology with the baby, he's just small, and that's constitutional. Unlike FGR, which is fetal growth restriction, in this the growth potential is not reached. There's some pathology with the baby. And what's the pathology? They're either going to suffer from hypoxia, asphyxia, hypoxic ischemic encephalopathy. They could be CP child, cerebral palsy, infection, hypoglycemia. All these factors are going to contribute to the FGR, and their growth potential is not reached. Unlike SGA, in which the babies have completely reached their growth potential. Now, during labor, you get the PGE2, which is prostaglandin E2 and prostaglandin F2 alpha, secreted from the choriodacidal layer. Okay, so if a woman is coming to you for the antenatal checkup before 12 weeks, you're going for the transvaginal ultrasound, and after 12 weeks, you're going for transabdominal ultrasound. Before 12 weeks, transvaginal. After 12 weeks, transabdominal. Next is the ALARA, which is as low as reasonably achievable principal limit, and this applies up to 10 weeks because the first 10 weeks are very important and very crucial in the terms of organosynthesis. So you have to keep the radiation dose as low as reasonably achievable. Now, this is a very, very high yield slide. I cannot emphasize more. At 4 to 5 weeks, you're going to see a gestational sac. At 5 weeks, you're going to see yolk sac. At 5 to 6 weeks, you're going to see the embryo. And at 6 weeks, you're going to see the fetal heart that is beating. The earlier the measurement you take, the more accurate the gestational age is, and the maximum limit is 20 weeks. And after 20 weeks, you cannot just rely upon your measurements. So it's good to take the measurement as soon as possible. Next is the lambda and peak sign, which is seen in the twins, and that is seen around about 9 to 10 weeks, which is the first trimester. Next is the neuronal migration disorder of the cerebrum, and that is seen in the third trimester. Next, you have soft markers, which are going to tell you about the Down syndrome, which is the chromosomal abnormalities, and you're going to look for these soft markers in the first trimester. Next is a low-lying placenta. Now, in any pregnancy, if you see a low-lying placenta at 20-week scan, just relax, don't panic. This low-lying placenta can migrate up later again into its original location. So you have to go for a repeated scan at 34 weeks if you see a low-lying placenta at 20 weeks. Next, if there is a positive history of preterm birth or mid-trimester loss, and that loss is mostly painless, that's because of the cervical incompetency. So you should go for the serial cervical length screening starting from 16 weeks through transvaginal ultrasound sonography. Now, if you talk about the amniotic fluid, you're going to measure the amniotic fluid levels in the third trimester, and you can measure it through two different ways. First is the AFI, which is amniotic fluid index, that ranges between 10 to 25 centimeters. Anything below 5 is called oligohydramnios, and anything above 25 is called polyhydramnios. Next thing you can measure amniotic fluid is through the max vertical pool length, and the range for it is from 2 to 8 centimeters. Next, a normal CTG recording is usually done for 30 minutes. In a normal CTG, you're going to see the normal fetal heart rate, and the normal fetal heart rate is 110 to 150. Below 110, ready. Above 150 is tacky. So next is the short-term variability. This is between two heartbeats, and the long-term variability is 2 to 6 times per minute. The fetus goes into the deep sleep cycle for 20 to 30 minutes. And if you talk about the accelerations and decelerations on CTG, accelerations are defined as increase in the heart rate of 15 beats per minute for 15 seconds. The same way decelerations are defined as decrease in the heart rate of 15 beats per minute for 15 seconds. And the normal baseline variability is 10 plus beats per minute. Now, if you conduct a biophysical profile and you get the score between 0 to 4, that's abnormal. If it's 6, you're going to repeat it again because it might be possible that the fetus is sleeping or it's in the deep sleep cycle. And if you get a score between 8 to 10, this is normal. Now, the uterine artery Doppler is usually done between 20 to 24 weeks. Next is the cerebroplacental ratio. Now, this is the ratio of the pulsatility of middle cerebral artery to the ratio of umbilical artery pulsatility. So it's just a ratio of MCA over UA pulsations. Next is small for gestational age. If it's late onset SGA, this is seen after 34 weeks, or if it's seen before 34 weeks, it's called early onset SGA. Late onset after 34 weeks, early onset before 34 weeks. CVS is usually done after 10 weeks. Very important. It is done after 10 weeks. Very, very important. I cannot emphasize more. The examiner is surely going to ask you about this. So CVS is done after 10 weeks. Result is going to take 48 hours. Full culture report is going to take 7 to 10 days, and the rate of miscarriage is around about 2%. Unlike CVS, a amniocentesis is going to take place after 15 weeks. So CVS for 10 weeks and amniocentesis for 15 weeks. Normally you're going to take 15 to 20 milliliters of sample. Result is going to take place within 48 hours, and the full culture reports requires 7 to 10 days. Rate of the miscarriage is least for amniocentesis. Very important. Rate of the miscarriage is least for the amniocentesis. Next is the chordocentesis. This is done after 20 weeks. So CVS for 10 after 10 weeks, amniocentesis after 15 weeks, and chordocentesis after 20 weeks. And the rate of miscarriage is highest for the chordocentesis. This is around about 2 to 5%. Okay, next we're going to talk about the Down syndrome. Now, in the first trimester, if you go for the Down syndrome screening, we're going to combine. Next, we're going to talk about the Down syndrome, and you're going to screen it in the first trimester and second trimester. And there are some other important points I would like to tell you about. Now, if you go for the Down syndrome screening in the first trimester, you're going to call it the combined screening. And for this, you're going to look for the knuckle translucency through the ultrasound scan. And you're going to do this in 11 plus 2 to 14 plus 1 weeks. You can also look for the crown rump length between 11 plus 2 weeks to 14 plus 1 week. You can also look for the blood tests, and these blood tests include HCG, pregnancy associated plasma protein A, and you're going to look for these blood tests between 10 weeks to 14 plus 1 weeks. Now, in the second trimester, you can also go for the Down syndrome screening, and This is called quadruple test. In this, you're going to look for the beta HCG, alpha fetoprotein, estradiol, and inhibin A. And all of these four values can be seen from 14 plus 2 weeks to 20 weeks. And then there are some other aspects through which you can go for the Down syndrome screening. You can look for the soft markers, for example, maxillary prominence or knuckle translucency, as already told in the first trimester. And you can also look for the CFF DNA, and you can look for it after 10 weeks. Very important. After 10 weeks, CFF DNA. You can also ask the mother about her age because the mother age is directly related to the risk for the Down syndrome. Next, in the third trimester, there's a highest risk for the symphysis pubic dysfunction, and hyperemesis gravidum is seen throughout the pregnancy, but it is most common in the first trimester only. If there's a patient with the obstetric cholestasis, I mean, her LFTs are getting deranged and she's getting jaundice, and this is mostly seen in the second half of the pregnancy. So, obstetric cholestasis is seen in the second half of the pregnancy, and in this case, you're going to deliver the baby after 37 weeks. Now, if the woman comes to you between 12 and 24 weeks and she's going to complain about the urine obstruction, that's because of the retroverted uterus. If there's a woman with the ovarian cyst and you plan to go for the surgery, you can go for the surgery either in late or early third trimester. So you can go for ovarian cyst surgery either in late second trimester or in early third trimester. Now this is very important. If there are more than 10 raised power 5 colonies of the bacteria on the sample, you're going to label it UTI. So in UTI, you're going to have more than 10 raised power 5 colonies of the bacteria. Very high yield. The examiner is surely going to ask you about this. I cannot emphasize more. The same way, if your midstream urine sample comes out to be positive with heavily mixed growth during pregnancy, you're going to repeat MSU after 1 week. So there's repeat MSU after 1 week if you get heavy mixed growth. Now, stalking for 2 years reduces post-thrombotic syndrome risk. This is important, 2 years. If you talk about postnatal obstetric thromboprophylaxis, and that really depends upon the risk of the patient. If the patient is low risk, you just go for the mobilization and hydration, and this is what the examiner is surely going to ask you about. If the patient is intermediate risk, start low molecular weight heparin for 10 days. And if the patient is high risk, you're going to start low molecular weight heparin for 6 weeks. Now, oligohydramnios is defined as amniotic fluid levels that are less than 5th centile on AFIs, and polyhydramnios are going to define as amniotic fluid levels which are more than 95th centile on AFI. The oblique and transverse fetal positions are problematic after 37 weeks. Very important. These are problematic after 37 weeks. Now you can attempt an external cephalic version at or after 37 weeks. Now very important. This 37 weeks is high yield. Now if a pregnancy goes beyond 42 weeks, this is postterm pregnancy. If during pregnancy you get a vaginal bleed before 24 weeks, this is threatened miscarriage, and if you get the vaginal bleed after 24 weeks, this is APH or antepartum hemorrhage. Before 24 weeks, threatened; after 24 weeks, APH. Now, fetal anemia is defined as the hemoglobin concentration less than 6 grams per deciliter. Normally, the fetal hemoglobin concentrations are more than 18 milligrams per deciliter, and the RBCs are highly packed with hemoglobin F. Now, if there's positive fetal anemia, you're going to plan for delivery after 37 weeks. Densely packed hemoglobin is something that is 30 grams per deciliter. Now, the fetal blood group genotyping via CFF DNA is usually assessed at 16 to 20 weeks. Okay, so now we're going to talk about twins. So, if there's splitting shortly after fertilization, you're going to see dichorionic, you get two placenta, and diamniotic, two amnions. So, you're going to see dichorionic, diamniotic twins if there is splitting shortly after fertilization. If they're splitting 4 to 8 days after fertilization, you're going to see monochorionic and diamniotic twins. They have one placenta and two amnions. And if they're splitting between 8 to 12 days, you're going to see monochorionic and monoamniotic twins. You get the one placenta, monochorionic, and you get the one amnion. This is monoamniotic, and you see twins. Now, if they're splitting past 30 days, you're going to see conjoined twins. Now, if there's a mother having multiple pregnancies, you're going to check for anemia first at 20 weeks and then at 28 weeks. Now, the vanishing twin syndrome phenomena occurs before first trimester. Very important, very high yield before first trimester. Now, in the twin pregnancy, there's a high incidence of spontaneous birth before 37 weeks, and you have to avoid delivery before 30 weeks at any cost. You have to take the pregnancy past 30 weeks if you want the twins to survive. Now, if you talk about the monochorionic, it means one placenta, and monoamniotic, I mean one amnion, but these are twins. So monochorionic, monoamniotic twins. So for monochorionic and monoamniotic twins, if you're planning for the C-section, then the optimal time for that is going to be between 32 and 34 weeks. If they are dichorionic twins, you get two different placentas like this. In the dichorionic twins, the optimum time for delivery is around about 37 to 38 weeks. In the monochorionic twins, in which you get the one placenta, the best time for the delivery is around about 36 to 38 weeks along with steroids. Now, if you don't deliver the twins by 38 weeks, they're going to die. For the triplets, the best time of delivery is around 32 weeks and the top limit is 34 weeks. For quadruplets, the delivery time is around about 28 weeks. For twin-to-twin transfusion syndrome, the best time for delivery is around 26 weeks. In twin-to-twin transfusion syndrome, you're going to see reversed A wave in the Doppler, and the Doppler belongs to ductus venosus, and you're going to see it from 11 to 13 weeks. So between 11 to 13 weeks, you're going to see a reversed A wave in the ductus venosus through the Doppler. Now the average weight for the triplet is around about 1.8 kilograms for each. Now in a TAPS, you're going to see unilateral AV anastomosis that measures less than 1 millimeter. Now what is the protocol for ultrasound in monochorionic pregnancy? You're going to do it fortnightly every 14 days from 16 weeks to 24 weeks. Now if you have a twin pregnancy and you just decide to kill one of the fetus, you can do it through fetoscopic laser ablation, and this is done between 16 to 26 weeks. Now the pregnant woman with the dichorionic twins needs to have at least 8 antenatal visits. The same way, the pregnant woman with monochorionic twins needs to have 9 antenatal visits, and the women with the triplets needs to have 11 antenatal visits. Now what is preterm labor? This is the onset of labor before 37 weeks, and the brain capacity for normal human is around about 1200 to 1600 milliliter. Now, what are the causes of preterm delivery? 50% are spontaneously, 25% are because of the premature rupture of membrane, which is called preprom, and 25% are because of the fetal or maternal indications. Now, if there's a second trimester, painless loss of the pregnancy, that's because of cervical weaknesses. And the treatment for it is the cervical cerclage. Chorioamnionitis is the inflammation of chorion and amnion, and this is seen at 32 weeks before birth. Now, what is the normal rupture of the membrane, which you can also call mature rupture of the membrane? Now, this is the rupture of the membranes during labor. Now, if it's before the labor, you're going to call abnormal or premature rupture. So, if it's during the labor, you're going to call it normal rupture of the membrane. So what is premature rupture of membrane? This is rupturing of the membrane after 37 weeks without onset of labor. Now, without onset of labor, you're going to call it premature rupture of the membrane. Now, this premature is telling you without the onset of membrane. And if it's after 37 weeks, you're going to simply call it prom. And if it's before 37 weeks, you're going to call it premature rupture of membranes. So this pre is going to tell you about before 37 weeks, and this premature is going to tell you about the rupture of membrane without onset of labor. So pre-prom is the rupture of membrane without onset of labor before 37 weeks. And if there is rupture of membrane after 37 weeks without onset of labor, you're simply going to call it prom. So you must know the difference between prom and p-prom. P-prom without onset before 37 weeks. Prom without onset and after 37 weeks. Now, if you plan to measure about the fetal fibronectin, which is going to tell you about the date of delivery, you can measure it from 22nd week to 36th week of gestation. Now, the best autolysis for 48 hours is through the prostaglandin inhibitors and calcium channel blockers. Conservative management for premature rupture of membrane, which is just pre-prom, is done before 34 weeks. If you see a patient with a pre-prom, you're going to induce labor if the patient has gone past 37 weeks. So after 37 weeks, you're going to induce labor in a patient with a pre-prom. Now, the tocolysis is contraindicated in pre-prom. This is very, very high yield. I cannot emphasize more. This is contraindicated in pre-prom. No tocolysis. Very high yield. Now, if there's a patient that complains of mid-trimester painless loss, that's because of cervical shortening. So for that, you're going to conduct serial cervical length through transvaginal ultrasound sonography, and this is usually done in second and early third trimester, or you can say just after 16 weeks. Now, if the length of the cervix is less than 25 millimeter, this is ultrasound indicated cerclage. If you want to go for the transabdominal cerclage, you can do it in the first trimester. In the second half of pregnancy, there is non-proteinuric gestational hypertension. So this is seen in second half of pregnancy. And if there's a high blood pressure in the first half of pregnancy, normally there's low blood pressure in the first half of pregnancy. That's because of natural vasodilation in the body. But unlike that, if you see a high blood pressure in the first half of the pregnancy, that's because of chronic underlying hypertension. You must go and evaluate for that. Normally, there's a fall in BP in the first trimester, so all the patients are advised to omit their antihypertensive drugs as there's already fall in the blood pressure, which is natural in the first trimester. Now, what is mild hypertension? This is blood pressure that ranges in 140s for systole and 90s for diastole. The same way in the moderate hypertension, you have blood pressure in 150s for systole and hundreds for diastole. If you talk about the severe hypertension, you have blood pressure more than 160 for systole and more than 110 for diastole. Now, what is preeclampsia? It is the hypertension that is more than 140 for systole and more than 90 for diastole. Also, if you go for 24 hours urine analysis, you're going to have readings more than 300 milligram of protein. So if there's more than 300 milligram of protein on 24 hours urine analysis along with hypertension, this is preeclampsia. Now this preeclampsia is screened at 20 weeks. Very important. This is screened at 20 weeks of gestation. This is noted twice, 4 hours apart, and this should generally resolve by 6 weeks after delivery. And if it doesn't resolve 6 weeks after delivery, then there's some underlying chronic hypertension and you must evaluate for that. Now, what is proteinuria? It is protein in the urine, 24 hours urine analysis that is more than 300 milligrams, or if you just don't go for 24 hours urine analysis and you decide to go for spot protein to creatinine ratio and the value comes more than 30 milligram per mole, this is proteinuria. Now, if there's a premature delivery before 34 weeks, you must use steroids to prevent RDS. Now, another important thing is that ergotamine should not be used in the third stage of labor. In a normal pregnancy, the preeclampsia usually doesn't occur before 34 weeks. However, if you see preeclampsia before 34 weeks, you have to do extensive research to exclude the underlying chronic hypertension or some related renal disease. Normally, in the first trimester, blood pressure naturally falls, so you have to discontinue the antihypertensive drugs in the first trimester. In the women with the antihypertensive medications, you should plan about the delivery around 39 weeks. Now, the blood pressure rises on the third and fourth postpartum days, and this is normal. SGA, which is small for gestation age, these are the babies that weigh less than the 10th centile. And now, what is the protocol for the SGA assessment? You have to see the crown rump length, and you're going to see it between 11 to 13 weeks. You'll also look for the head circumference, and you're going to do it between 14 to 20 weeks, and then you're going for serial biometry every 4 weeks. That was the protocol for the SGN. Now, what is the protocol for FGR? First, you're going for the serial biometry, and the duration between two tests should not be less than 2 weeks. The same way you're going for the amniotic fluid, and again, the duration between two tests should not be less than 2 weeks again. Then you're going to look for the umbilical, arterial, and venous Doppler along with the CTG. Now, the HbA1c in the pregnancy should be less than 6.8. This must be your goal. Folic acid is given in high doses in pregnancy, especially in the first trimester, and the high dose is around about 5 milligrams per day. Organogenesis period is the first 42 days in the pregnancy where the fetus makes most of its organs. Now, if the HbA1c is more than 9, there's increased risk of fetal loss. So your targeted blood glucose levels should be around about between 70 to 125 milligrams per deciliter. In the diabetic mothers, there's the highest risk of stillbirth in the third trimester. Very important. Highest risk of stillbirth in the third trimester. In the diabetic patient, you have to start low dose aspirin from 12th week. And if you talk about the diabetic retinopathy screening protocol, you'll screen for the diabetic retinopathy at booking, followed by screening again at 16 to 20 weeks, followed by screening again at 28 weeks. For all the pregnant diabetic ladies, you have to check the glucose levels at least 7 times a day. That's too much. In the second half of the trimester, there's increased requirement of everything, so you have to increase the dose of insulin and metformin in the second half of the trimester. Anomaly scan, this is usually done between 20 to 22 weeks. In the diabetic pregnant patients, you have to go for the vaginal delivery between 38 to 39 weeks. How are you going to label a patient positive with the GDM? First, check the fasting glucose level and it comes out more than 100 milligrams per deciliter, it's positive GDM. Second, if you go for postprandial 2 hours glucose level and they turn out to be more than 140 milligram per deciliter, your patient is going to be GDM positive again. So these are the two criterias. Now, after pregnancy, you'll go for fasting or HbA1c level screening, and this screening is usually done between 6 to 13 weeks after birth. So after pregnancy, you'll screen for the diabetes again through fasting or HbA1c levels between 6 to 13 weeks after birth. Next, if there's patient with the cardiac issues, you're going to conduct echocardiography at booking, and second, around 28 weeks. And if you see aortic dilatation more than 4 centimeter, this is significantly dilated aortic root. In the pregnant cardiac patient, second stage of the labor is kept short. This is very, very high yield. I cannot emphasize more. Now, the incidence of ischemic heart disease peaks around the third trimester. All the pregnant patients should avoid going for stunt placement between 8 to 15 weeks. Now, the patients with the mitral stenosis can develop pulmonary edema at 30 weeks. This is very important, very high yield mitral stenosis leading to pulmonary edema. The examiner is surely going to ask you about this. Now, what is secondary postpartum hemorrhage? That is any bleed that starts from 24 hours and continues up to 6 weeks after delivery. Now, the most common time for the secondary PPH is between 7 to 14 days. In pulmonary embolism, if you suspect a patient if you suspect pulmonary embolism in some patient, you must conduct lung scan within 24 to 48 hours. What is puerperal pyrexia? Pyrexia means fever. So it is temperature of 38 plus degrees centigrade that is noted twice in 10 days postpartum, excluding the first 24 days. After delivery, chest complications are most likely going to happen in the first 24 hours. Postnatal pains, it's the period of 24 to 48 hours after delivery. Postnatal blues, it is the first 2 weeks after delivery, and non-psychotic depression is the first year after delivery, and it usually recovers in 3 to 6 months. Now, early postnatal depression is sudden and before 6 weeks. So, sudden before 6 week depression is the early postnatal depression. The same way, late natal depression is gradual after 6 weeks. So, gradual and after 6 weeks, it is natal depression. Now, for the assessment of mood in a postpartum patient, you have to ask about the mood twice. First at 6 weeks and second between 3 to 4 months. So this is the generally protocol for mood assessment in a postpartum patient. Next is the puerperal psychosis. This is seen on the 5th postpartum day. Now the antidepressants are going to take 10 to 4 days to work. It must be continued for 6 months. Now the psychosis recovers in 4 to 6 weeks with the treatment. If you want to talk about the breast is located between second and sixth rib, and it has 15 to 25 TDLS, which is terminal duct lobular system, which is the functional units of the breast. Now within 2 weeks of hormonal stimulation, these breasts start producing milk. The colostrum production starts at 16 week of pregnancy. On second postpartum day, this milk is going to replace the colostrum. Now when the fetus starts sucking, it's usually going to take 45 minutes for the prolactin levels to rise. Now in the second week, the best method, or you can say the method of choice for lactation suppression is number 1, fluid restriction, number 2, tight bras. Rusty pipe syndrome is seen in late pregnancy and early breastfeeding. It can usually last up to 1 week. Sensitive nipples, they are seen in 1 week after breastfeeding, and they usually worsen. They are associated with cracks or abscesses, candida, or poor position of the fetus. Breast engorgement, this usually starts at second and third postpartum day. Now there are different methods for the postpartum contraception. First one is the IUD. After the postpartum period, you have to wait for 4 to 8 weeks before you want to place an intrauterine device. Next is the progesterone only pill, also known as mini pill. You can use it after 21 days. You can also go for the injectable progesterones, but you have to wait for 5 to 6 weeks, and you can really go for the medroxyprogesterone. This is injected after every 3 months, or you can go for the northestrone, which is injected after every 2 months. You can go for the tubal ligation. This can be done during C-section. You can also go for mini laparotomy ligation, and this can also be done in the first few days. You can also go for the laparoscopic ligation, and this is usually done at 6 weeks. 3 weeks after delivery, you can go for contraceptive pills, and this is for non-lactating mothers. In non-lactating mothers, ovulation normally starts after delivery by 4 to 6 weeks.